Hello and welcome to the Journal Club. Today we're going to have a trial 65, which is going to be presented by Ishay and Ash. So I'll hand you over to those to start their presentation.
Okay, hi everybody.
Hello everyone.
I haven't got a video on.
I'm Ishay, one of the ITU doctors.
And I'm Ashni, I'm one of the junior doctors. Sorry, we're just going to close the door, it's really noisy. So today we're presenting on 65 trial, which is called Effective Reduced Exposure to Vasopressors on 90-Day Mortality in Older Critically Ill Patients with Vasodilatory Hypertension. So just a little bit about the background of it. So OVATION and SEPSISPAM are two trials that evaluated MAP targets. SEPSISPAM was a trial in France and OVATION was a trial in Canada. And then they suggest that increased exposure to vasopressors resulting from higher MAP targets is potentially associated with an increased risk of death in a subgroup of older patients, but the difference was not statistically significant. So the studies evaluated interaction of MAP target and age, but their conclusions were not statistically significant. So a bit of background. So we know that Rivers did a trial in 2001, which was about the management of severe sepsis and septic shock. And then there was a surviving sepsis campaign, which recommended targeting a MAP of at least 65 millimeters of mercury in patients with septic shock. So this led to subsequent trials, ARISE, which was in Australia, and PROMISE, which is one in the UK, which assessed aspects of early goal-directed therapy, but none of these trials gave firm conclusions on MAP targets. So why bother doing the trial? Basically, vasopressors are not without risk. As we know, they reduce blood flow to vasoconstricted vascular beds. And as mentioned earlier in the SEPSISPAM trial, there was a higher mortality in those with higher MAP targets in the subgroup of elderly patients. So this takes us to the clinical question. What is the effect on mortality at 90 days of reducing the exposure to vasopressors through permissive hypotension in ICU patients aged 65 years or older receiving vasopressors for vasodilatory hypotension? So essentially they're trying to determine whether reducing exposure to vasopressors by targeting a MAP of 60 to 65 would decrease 90-day mortality in ICU patients. So this was a multi-center parallel group randomized clinical trial. It was one-to-one randomization. So target permissive hypotension, which was a MAP goal of 60 to 65 versus usual care, which was at the discretion of treating clinicians. And it was web-based randomization system. It was implemented in 65 ICUs in the UK, and it involved 2,455 patients over 65 years old being treated for vasopressors for management vasodilatory hypertension. So that's the inclusion criteria, which I'll let you read. Just older than 65, patients within less than 6 hours of vasopressor initiation, and they were adequately fluid resuscitated. So common management and intervention between the two groups. So vasopressors were guided by MAP target of 60 to 65, or according to usual care, so discretion of treating clinicians. The MAP target was reinforced through trial-specific prompts. So the infusion pumps had alarms which went off when they reached a certain MAP, and then that prompted like dosing to be increased or decreased. The choice of vasopressor and other treatments were at the discretion of treating clinicians, and there's a list of vasopressors. I think there's epinephrine, phenylephrine, just the normal ones. And then allocated intervention was administered throughout the ICU stay, And inotropes didn't affect the study protocol, so things like dobutamine could be freely used in both groups.
So in terms of results, the main primary result is that there was a non-significant trend towards a reduction in mortality at 90 days in the permissive hypertension group. So as expected, patients in the permissive hypertension group had a lower average MAP compared to the unrestricted one, where it was less than 6 millimeters of mercury in terms of blood pressure, with a mean of 66.7 versus 72.6. Although of note, we were aiming between 60 and 65. Our mean was actually 66.7. And as expected, the group with the lower MAP targets needed less vasopressors, median of 33 hours versus 38 hours, so a difference of 5. And looking at other interventions that were implemented, such as steroid use, fluid balance, and there was no difference between the two largely. And in terms of serious adverse outcomes, there wasn't much difference between the two. So if we're just looking at the 90-day mortality, in our permissive hypertensive group, we had a 41% mortality, whereas compared to 43.8 mortality, which is a difference of absolute of about 3%. But of note, it was, the p-value is 0.15, so it's not statistically significant. And our odds ratio as well at 90-day, adjusted odds ratio at 90-day mortality is 0.82, which is less than 1. And if we're looking at overall survival, we note that between the two groups, there were largely similar outcomes within the first month, and then after that, they slowly start to diverge. But in terms of where they end up after 12 months is relatively similar points. And there was no statistical difference between the two groups. Now, if we look at secondary outcomes, so this is our mortality in ICU stay, duration of being in hospital, length of stay, cognitive decline, and quality of life. All these secondary parameters, there wasn't really a significant difference between the two groups. And just what was quite interesting from this study is that although there wasn't anything statistically different between the two groups, there was a trend towards better outcomes in patients with chronic hypertension and were in the permissive hypertensive group. For example, the 90-day mortality was 38.2 in the chronic hypertensive group versus 44.3, whereas patients without any hypertension at 90-day mortality was very much so similar between the two. And like mentioned earlier on, the amount of vasopressors that was needed was less in the permissive hypertensive group compared to the second group, which is what we would expect. And lastly, just to say the mean arterial pressures between the two groups was 66.7 versus 72.6, with a peak of 83 versus 92. So the key findings of the study is that there's a non-significant reduction in mortality between groups where patients are given lower vasopressors and a lower MAP target. There's also a reduction in vasopressors. And lastly, secondary outcomes are kind of similar between the two groups. So in terms of the strength of the paper, it was a large multi-center study, and there was a good retention. More than 95% of patients who were enrolled into the study who kept on being in the study. So the intention to treat analysis was good. All patients who were enrolled in the study and randomized were actually included in the statistical analysis, giving more weight to the paper. And there was a near complete follow-up and a good adherence to the MAPs. So in terms of limitations, the main one is that although we're aiming for a MAP of between 60 and 65 in the permissive hypertension group, largely the average in the group was 66.7, if I'm correct. So we didn't quite, in the study, they didn't quite stick in those parameters, which they found quite difficult to do. And the mortality rates on this slide that I showed, they start diverging after a month or so. So it's difficult to just say that the stay in ITU was predominantly the difference between the two. And then lastly, the separation in blood pressure was considerably low and there was some overlap between the two. And looking at the secondary outcomes, there wasn't really a difference between the two groups. So it's difficult to kind of then say, why is the use of less vasopressors causing a difference between the two groups? And the last big question is, will this change practice? So it's difficult to say because sometimes I see we accept a MAP above 60, or sometimes we push for a higher MAP in patients with chronic hypertension because we think that they need a higher MAP to drive perfusion across their organs. But this study did show that we could actually probably accept a lower MAP, and it's likely okay to use less vasopressors than we normally do. So some of the rationale that they try to push for this is that we know that systemic perfusion pressure, which is the pressure that drives blood through the organs, is primarily affected by the MAP and the central venous pressure. And if we have a higher central venous pressure, so pumping fluids into a patient, then we'll likely need a higher MAP to maintain a good systemic perfusion pressure. However, if we have a lower CVP, then we likely need a lower MAP to drive systemic perfusion pressure. Then that begs the question of whether, after initially fluid resuscitating our patients, should we be pouring bucket loads of fluids into them, or should we maybe take a more conservative approach to our fluid management with our patients? So in conclusion, it appears safe to target a MAP between 60 and 65 in elderly patients with VADS or dilatory shock. And in the two groups, there was a potential mortality benefit, although not statistically significant, with the use of permissive hypertension in patients that have chronic hypertension. The exact reason or explanation for this, I couldn't quite find why. And that is a reference. Thank you very much.
Thank you.
Thank you very much for your presentation, Ishay and Ash. Very interesting topic. So I'm going to now open the floor to any questions that anyone has available. So if you just want to unmute yourself and then ask any questions, if anyone has any. Or you can type it in the chat if you have other questions, and then I can just read it out. So I have one question for Ishay and Ash. So we normally do target a MAP of 65 for patients. Normally, anyway, that is kind of the minimum that we would kind of accept. What do you think about this paper in terms of actually giving us more information? Because we normally do that as a, as a standard care, we target patients with a MAP of 65. What do you think? Would you think this paper might be a bit more kind of useful if it targeted actually a lower MAP, perhaps maybe a MAP of 55 or a MAP of 50? What do you think?
So in terms of 60 to 65, I think a lower MAP would have been difficult, I think, the main problem that they found with trying to target a MAP between 60 and 65 is that it was mostly predominantly to the discretion of the nursing staff. So they're the ones who normally titrate the vasopressors. So I think it would be quite difficult to have a MAP of 55 and still maintain our perfusion of our organs. It's rather a bit difficult for me to answer per se and see whether that's something that's safe to do in patients, and whether actually, if we aim for a MAP of 55, will our patients end up getting a MAP of 50 or 45, considering that they were tightly monitored, whereas our patients, although we monitor them quite regularly and frequently, there might be some adverse effects to having such a low MAP.
Okay, thank you.
And I think the take-home message, rather than what the MAP was because in the paper is that we could probably use less vasopressors and they don't come without any side effects for our patients. So as long as they're perfusing their kidneys okay and fusing all their end organs okay, MAP of lower than 65, between 60 and 65 is probably accepted, can be accepted.
Because then it's also easy, it takes a shorter time to get them off it, so to wean them off the vasopressors if you use a lower dose.
Okay, thank you. So we have a few questions as well from the audience. So we have a question from our consultant, Dr. Melanjam. Does it mention anything about specific patient groups, example, head injury, bowel anastomosis, where we might be considering targeting different kind of MAP values?
So I didn't really mention those, and those patients were excluded. I think we've got exclusion criteria.
Yeah.
Okay, let me just find that.
There we go.
So in specific patients who needed targeted MAPs, those patients were excluded from the trial. So patients that had brain injury or spinal cord injury, patients with solely bleeding or cardiac failure, post-CABG vasopressia. So patients in which there's evidence that specific MAP targets, they were excluded from the study, and it was primarily focusing on distributive shock. And the patients we aim for about 65 and above MAP.
Okay, perfect. And then I think Alex's question is very similar. Is there a scenario where we should be aiming for a MAP of more than 65?
From the study, they didn't say that the specific scenarios that we should be aiming for that. It just did say that what we primarily tended to think that in chronic hypertensive patients, you need a higher MAP to drive perfusion. That wasn't really what they found in the study, and that a MAP of about 60, you can probably get away with that and you won't have any adverse effects on your patients. I think the worry for us is if we aim for a MAP of 60, will we actually reach that, and whether patients will have a lower MAP than that.
And then we have a question from Abrar, who's asked that he's seen patients with hypertension get higher MAPs valued at 70. Should we be trying to aim for a lower MAP for these patients of less than 65, specifically in the ITU setting?
I think not necessarily aiming for a lower MAP, but we should go for a MAP of 65, which we go with, I think, for our usual patients. And only after that, if we are struggling to perfuse our organs, then we can potentially go up to a higher MAP to drive perfusion.
And then we have a comment from Dr. Wilkinson, who said that we never pour in IV fluids into patients. This trial demonstrates, although secondary, that chasing MAPs excessively possibly delays discharge, leads to more interventions and more fluid overload. Early goal-directed trials where we overtreat all demonstrate this nicely, and no one has replicated Rivers because he oversaw all the participants, and they were post-surgical cohorts, which is not generalizable to the rest of the ITU population.
Yeah, so
can I say something?
Yeah.
Sorry, I'm echoing in the room. Hang on. I mean, I think they produced this paper after this SEPSISPAM, or however you say it, trial, which looked at when they were aiming for really, really high targets like 80, 85 versus 65 in severe sepsis. And they didn't find any mortality difference between the two groups. But what they did found was with the people that had, Johnny's trying to steal my identity.
Sorry.
They did find that the patients that they aimed for more like 80, 85, especially if they're chronic hypertensives, that they have less renal failure and less requirements for renal replacement therapy, which in turn affected their mortality. So I think we have to be very careful in high-risk patients, your chronic hypertensives, aiming for very low mean arterial pressures. But at the same time, I mean, you have to remember this study, they very clearly showed that they didn't aim for a MAP of 60. That isn't what they achieved at all. They achieved 65, which is essentially what we do anyway. But I think it does prove that, you know, we can be a bit better with our, you know.
Oh, it's in your pot.
Sorry, what? Did you say something, Liv?
Sorry, it's my 5-year-old.
I thought it might be. Hi, Sophia. Yeah, that's my comment.
Mm-hmm.
Sorry, and we have one question from Zakia or comment. With the higher MAP targets in hypertensive patients have something to do with the shift in autoregulatory curves? And I think that is, yes, definitely that's why we would try and aim for a higher MAP target, yes, in those kind of patients. So I think, have we got any more questions? Anyone else want to have any more comments or questions to Ishay and Ash?
In reply to what Alex has written, does this trial suggest there's little evidence to support the fact that we should be targeting higher MAPs? I think in a way it does, indeed, and I think that's why we're saying we shouldn't be perhaps aiming for higher targets necessarily in our chronic hypertensives. But if you do look at the sepsis at PAM study, they show improvements in terms of needing renal replacement therapy and not mortality in those groups that had a higher target. But I think this does prove that actually not necessarily, but I don't think it necessarily proves it's okay to aim for a MAP of 60 either, because they didn't target a MAP of 60. They didn't achieve it anyway. But I think it does show that actually, if you've got an elderly patient over, like Johnny said, if you've got an elderly patient over the age of 65 and they don't have any comorbidities, you know, they're not hypertensive normally, then you probably could target a MAP of 60 and not worry too much about it, because actually what you're probably doing is preventing them from being discharged because they need MAP, you know, NORAD overnight or whatever, because they're dropping their blood pressure at night when they're asleep. As long as they're peeing, then I think that's what it does suggest.
Okay, I think if no one else has any more comments or questions, I think we'll end it there for today. Thank you very much, everyone. And thank you, Ash and Ishay, again for your presentation. And we'll see you next week, hopefully.